My name is Henry Lim. I'm the president of International League of Dermatological Societies. On behalf of ILDS, I'd like to welcome all of you to participate in this inaugural webinar organized by ILDS Education Committee. The Education Committee is a relatively new committee that has been established a few years ago. It is under the leadership of Rashmi Sakar and Ricardo Romici. Photos of the members are listed here, and on the right-hand side, photos of our superb staff, Emma Van Rohen and Jennifer Kilmer. The Education Committee has the purpose of advancing global dermatological education to create accessible, high-quality resource and to initiate the member organization involvement in improving skin health for all. Our plan is to oversee the coordination of all education materials, which we have quite a robust collection of, to develop a new series of webinars, and this is one of them, to evaluate external proposal for educational providers to the ILDS, and this we receive on a regular basis, and to guarantee accessibility of all the resources to members of our member organizations. This inaugural seminar is addressing leprosy and neglected tropical diseases. This is timed to occur with the World Leprosy Day. All of you are very familiar. Leprosy is a neglected tropical disease, which is still very, very prevalent in many countries. And World Leprosy Day is observed annually at the last Sunday of January and observed on the 30th of January, specifically in India, to honor Mahatma Gandhi. The aim of these days is to raise awareness and to combat stigma attached to leprosy. This is also timed to the World Neglected Tropical Disease Day, NTD Day. You all are very familiar that NTD affects over 1.6 billion people globally, especially in underserved communities around the world. Skin-related NTDs, such as leprosy, leishmaniasis, and mycetoma, affect an estimated of 1 billion people. World Health Assembly recognized the 30th of January as World NTD Day, and that is why this seminar also is timed with this particular event. So with that, I'd like to again thank all of you. I'd like to thank Rashmi Sakar, Ricardo Romici, and the rest of the committee, as well as the staff, for organizing this particular day. With this, I'd like to turn this over to Dr. Sakar for the rest of the program. Thank you very much.
Hello everyone, and I'm Dr. Rashmi Sarkar. I'm the chair of the ILDS Education Committee, which has been so kindly introduced by the President ILDS, Professor Henry Lim, and I'm also a board member and a regional director of ILDS. I also happen to be the Director Professor of Dermatology in Lady Hardinge Medical College and Associated Hospitals, New Delhi, India. It's a pleasure that from the ILDS Education Committee, we are introducing you to the ILDS Masterclass webinars, which we are going to have from time to time. And I hope all of our ILDS member societies really find these informative and useful. Do share your feedback. So today I'm going to introduce our very first ILDS Masterclass webinar with experts all around the world, and that's going to be on the World Leprosy and Neglected Tropical Diseases Day. The committee members have been introduced to you by Professor Henry Lim, and I'm the chair, and Dr. Ricardo Rometti is the vice chair. These are the other members, and the ex officio members are, of course, Professor Henry Lim, as well as Dr. Yvonne Arellano. And we have the secretariat support who are very helpful with that is Emma Van Ruhen and Jennifer Kilmer. Now, first of all, on 31st of May 2021, the World Health Assembly recognized 30th January as World Neglected Tropical Disease Day. It is observed on January 30th because it marks the anniversary of the 2012 London Declaration on NTDs, where governments and the global community pledged commitment towards raising awareness about and eliminating these diseases. In India, there is an added significance of this day as the World Leprosy Day is observed every year on this date, and this coincides with the death anniversary of Mahatma Gandhi, the father of the nation. World over, the last Sunday of January is observed as World Leprosy Day, and that is why we thought that it is significant that we put this webinar together on the World Leprosy and the Neglected Tropical Diseases Day for you. Now, NTDs or neglected tropical diseases are a group of infectious diseases that disproportionately affect the world's poorest population, often in the remote or underserved areas. These diseases, such as leprosy, schistosomiasis, and river blindness, contribute to social stigma, disability, and economic hardship. Now, the term NTDs includes 21 diseases, out of which the ones with dermatological relevance are Buruli's ulcer, cutaneous leishmaniasis, leprosy, lymphatic filariasis, mycetoma, onchocerciasis, post-Kala-azar dermal leishmaniasis, scabies, and yaws. The World NTD Day serves as a platform to highlight the need for increased investment in prevention, treatment, and research, while also advocating for global partnerships to eliminate these diseases and addresses health inequities. And this is something that the ILDS strongly stands for. I'm going to introduce you to three of our global expert speakers who are a delight to hear. And the first is Professor M. Ramam from New Delhi, India. And he's going to talk to you about mimics of leprosy, which is going to be a very interesting talk. Dr. M. Ramam is Professor and NEC of the Department of Dermatology and Venereology at the All India Institute of Medical Sciences, New Delhi, India. His areas of clinical and research interest are granulomatous diseases, pigmentary disorders, dermatopathology, and psychosocial aspects of skin diseases, and he is a global expert on all these conditions. He enjoys teaching and he has students who are all over the world. The next person who's going to speak is Professor Ri Yotsu from USA, Japan, and she'll be speaking on Buruli's ulcer and non-tubercular mycobacterial infections. Dr. Ri Yotsu is an associate professor at the Tulane School of Public Health and Tropical Medicine at Tulane University. She is a pioneer in the field of neglected tropical diseases and has mentored students from Japan, USA, and Côte d'Ivoire and works as a consultant for WHO. In her own words, she combines her love for dermatology and also public health to treat neglected tropical diseases. The third speaker is from Ethiopia, Africa, Professor Wendemagegn Enbiale, and he's going to give you a mycetoma update. He is a professor at Bahir Dar University, Ethiopia, and is the CEO of Selam Global Health Consultancy, contributing significantly to skin NTDs, outbreak management, community-based research, and clinical trials. He is a member of the WHO Strategic and Technical Advisory Group for NTDs and also the vice chair of GLODERM, which mentors students all across the world. He has over 22 years of experience in clinical care, research, and global health. So I'm sure that they are going to give talks which are going to be very informative and at the same time very enjoyable. Meanwhile, if you have any questions, please submit any questions or comments in the YouTube live chat that you are seeing, or email me at rashmisarkar@gmail.com or Jennifer Kilmer, that is J Kilmer, at ilds.org, and we can answer some here and some subsequently. So, thank you so much and stay tuned for all these wonderful talks.
Good day to all of you. Leprosy continues to be a problem in several parts of the world, as this WHO map shows us. And dermatologists have an important role in making the diagnosis and providing care, because many of the clinical findings are in the skin. As you can see in this collage, leprosy has a set of identifiable manifestations which spans a wide spectrum of findings. And naturally, there are other diseases also which can share these features and can potentially cause diagnostic confusion. Once again, dermatologists are well placed to recognize these other disorders and ensure that they are treated properly. I thought a good way to discuss skin conditions that resemble leprosy would be to take a quick look at the findings in leprosy and then look at the condition that resembles it. I thought we could start with one end of the spectrum, which is tuberculoid leprosy. And in tuberculoid leprosy, lesions are usually single, or you might have a few, 1 to 3, confined to one anatomic sites. Margins are usually very well defined. Sensory loss is marked in these plaques. There's almost complete anesthesia. There's loss of sweating and loss of hair often present. Some lesions are raised like the one we saw, but you can also have sharply defined anesthetic macules with some elevation of the periphery, as is occurring in this patient. Hypopigmentation tends to be quite prominent in lesions of tuberculoid leprosy. When localization is imperfect, as in borderline tuberculoid leprosy, you can get small satellite lesions developing adjacent to the main plaque. And if you run a finger along the edges of a tuberculoid lesion, you might encounter a thickened sensory nerve, and that would also be a clue to the diagnosis. Of course, we always palpate the regional nerve in these patients. Here, the nerve is visibly thickened, but if you palpate for the nerve, you might find that it is thickened, beaded, and or tender. Here it is the greater auricular nerve, which is thickened and can be seen in the neck. This nerve involvement leads to loss of function in the area supplied by the nerve, and that can manifest as a sensory motor neuropathy with loss of sensation and muscle weakness. So having looked at one standard presentation of tuberculoid leprosy, let's look at a mimic of tuberculoid leprosy. This is a patient who presented with a hypopigmented macule with loss of hair, striking loss of hair within the macule. Here is another patient with a similar finding, hypopigmented macule and a loss of hair. That is the site of a punch biopsy, not a part of the clinical lesion. Now, in a leprosy endemic country, in a patient like this, you would test sensation, and critically, both these patients showed no sensory loss at all. But if you have 2 out of 3 findings, you often get treated for the disease. And this is what happened with these patients. Because they had hypopigmentation and loss of hair, they received treatment for leprosy. But when there was no response, the patient was biopsied. And this is what we saw. There were infiltrates in the upper and mid dermis. And the infiltrates are moderately severe. And given the clinical context, this could very well get signed out as indeterminate leprosy. But there is an important additional finding that tells us that this is not indeterminate leprosy. And that finding is this one. Let's look at it in higher power. What we see is follicular spongiosis. And this is a clue to the diagnosis of hypopigmenting dermatitis or truncal pityriasis alba, and a pointer away from the diagnosis of leprosy. Here is another example of the finding. Not much in the dermis except some perivascular infiltrates, but the follicular epithelium does show this change of spongiosis and exocytosis of lymphocytes. So if you have a patient suspected to have macular leprosy who doesn't show sensory loss, then follicular spongiosis will point you to the correct diagnosis, which is, as we said, hypopigmenting dermatitis or truncal pityriasis alba, if you prefer. Now let's move across to the other end of the leprosy spectrum and look at lepromatous leprosy. What's the usual clinical presentation before we look at the mimic? Lepromatous leprosy presents with multiple hypopigmented small vacuoles with little or no sensory loss. There might be diffuse infiltration of the skin, and you might have loss of eyebrows, as this young man does here. As disease progresses, skin-colored nodules develop in the areas of infiltration. And lepromatous leprosy has glove and stocking anesthesia. Neuropathy sets in later in lepromatous disease, but is widespread and symmetrical. And you might get trophic blisters and fissures in these patients. And if it's neglected, there can be more extensive damage. So that is the usual clinical presentation of lepromatous leprosy. Now let's look at a mimic of lepromatous leprosy. And this is a really close mimic. There are multiple small hypopigmented macules over many areas of the skin, including the face. There is a diffuse infiltration of the skin that's prominent on the face, and see how similar this is to the patients with lepromatous leprosy we saw just now. These patients do not have loss of eyebrows, but they have pretty prominent infiltration. And with advanced disease, they begin to show nodules too, again, quite similar to lepromatous leprosy. And if you chose to call this a leonine facies, I think nobody would argue with you. However, and this is also really important, is that there's never any sensory loss in these patients and no nerve involvement. But because of this dramatic similarity to lepromatous leprosy, many of these patients do get registered in leprosy clinics and receive treatment, but clearly they do not improve. So what's the right diagnosis if it is not lepromatous leprosy? The correct diagnosis in these patients is post-Kala-Azar dermal leishmaniasis. So post-Kala-Azar dermal leishmaniasis is one of those rare names in dermatology that makes sense. Unlike, for example, dermatitis herpetiformis, which is neither a dermatitis nor herpes, post-Kala-Azar dermal leishmaniasis is what it says it is. It's post-Kala-Azar because it follows Kala-Azar, which is another name for visceral leishmaniasis. Not everybody who has Kala-Azar develops post-Kala-Azar dermal leishmaniasis. About 1 in 10 to 1 in 20 people do. And it's dermal leishmaniasis because at this stage of disease, the infection is confined entirely to the skin. Visceral leishmaniasis is a systemic disseminated infection of the reticuloendothelial system, but post-Kala-Azar dermal leishmaniasis, which occurs about 6 months to sometimes up to several years after the visceral infection, at this stage, the organisms, leishmania bodies are only seen in the skin. And as we saw, the clinical appearance can very closely resemble lepromatous leprosy. And because both these diseases occur in an area that is endemic for both infections, the mistake is often made. So far we've looked at tuberculoid leprosy and its mimic, and lepromatous leprosy and its mimic. I want to close by talking about reactional leprosy and showing you a mimic of that. Now, reaction in leprosy are acute episodes that interrupt the chronic course of leprosy. And there are two types of reactions. Type 1 reactions, which we're going to talk about now, are characterized by inflammation in pre-existing skin lesions and nerve lesions, and that may be accompanied by new inflammatory lesions. Type 2 lepra reactions, on the other hand, you don't get inflammation of pre-existing lesions, but you do get new inflammatory nodules in the skin that are transient and last for about 4 to 5 days individually, though the process can go on for quite a while. But for reasons of time, I'm only going to talk about a type 1 lepra reaction and show you a mimic of that. So this is what a type 1 lepra reaction looks like in its standard presentation. A pre-existing hypopigmented macule or plaque becomes swollen or erythematous. If the reaction is severe, the plaque may actually ulcerate because of the inflammation, and we see that in both these patients. Severe reactions may be accompanied by swellings of the hands and feet, and there's marked inflammation in nerves, which is one of the feared complications of a type 1 reaction. You might develop new sensory and motor deficits acutely, and this requires prompt treatment with systemic corticosteroids. So that's the classic type 1 reaction presentation. Now let's look at a mimic of a type 1 reaction. Here is somebody who has an inflammatory edematous plaque on the chin adjacent to the lower lip. She did not have a hypopigmented lesion prior to the onset of this plaque, but we know that roughly 10% of patients will present for the first time to the healthcare system with a type 1 reaction or a type 2 reaction without having had disease previously. So that was what the assumption was in this patient. A clinical and biopsy diagnosis of tuberculoid leprosy in type 1 reaction was made, and the patient received anti-leprosy treatment but did not improve. So she was reassessed, and on reassessment, we made a diagnosis of orofacial granulomatosis or Merkelson-Rosenthal syndrome. Now, this is a condition that is fairly easy to recognize when it affects the lips, producing granulomatous cheilitis. Clinically, you have swellings that come and go and then become persistent and indurated. And at that stage, you will see granulomas on biopsy. You can also recognize the Merkelson-Rosenthal syndrome when it presents with facial nerve palsy as a part of the triad, which is facial nerve palsy, facial swelling, and a scrotal tongue. But it's important to know that it can also present as an inflammatory plaque on other parts of the face and then might be mistaken for reactional leprosy. So what we've done in the last 10 or 11 minutes is look at some of the clinical manifestations of leprosy and also look at the many diseases, some of the multiple diseases that can look like leprosy. And we have the subtext of my presentation has been that dermatologists have an important role both in recognizing leprosy and in also recognizing diseases that look like leprosy but are not, so that these patients receive the appropriate treatment. Thank you very much for your attention.
Good morning, good afternoon, and good evening to every one of you who are joining us for this World NTD Day Celebration Lecture 2025. I'm Yotsu. I'm the Associate Professor at Tulane University in the United States. I'd like to first of all thank the ILDS for having me to lecture on this special day. Today I will be talking to you about neglected and misdiagnosed cutaneous non-tuberculous mycobacterial infections, with focus on Buruli ulcer. Many of us know that Buruli ulcer is among the rest of the NTDs. However, there are also other mycobacterial diseases that causes skin manifestations which are neglected. And today I would like to be talking to you about these conditions. So why non-tuberculous mycobacterial infections matters in dermatology? Overall, there are around 200 species of Mycobacteria identified globally, which includes all kinds of Mycobacteria, including tuberculosis and leprosy, which all of us know. But among them, most of them are identified as this non-tuberculous Mycobacteria, NTMs, which are widely distributed in soil, water, and plants. Among them, around 20 species are known to cause cutaneous infections, known as the Cutaneous NTM infections. And there is an awareness that these cases are increasing, but often neglected burden in dermatologies, as there is no surveillance in place. These are some of the cases of cutaneous NTMs, which is this is a Mycobacterium malinum. You can see that this nodule of plaque on dorsal of the hands, multiple lesions, but lacks in inflammatory symptoms. This is also another case of Mycobacterium malinum, very similar presentation, but this one you can see some of the ulceration starting in the center. As the name shows, malinum is sea, water, and so these cases are often occurs in patients who have this contact with some tropical fish and some aquatic environment. This is a patient with abscess, which was found to be Mycobacterium avium, which also he had some pulmonary infection with the same Mycobacteria. And when you drain the abscess from this patient, often in these kind of cases, you find very thick yellowish pus, which are characteristic of mycobacterial disease. And then when you have this, you can suspect your differential diagnosis, one of your differential diagnosis to be cutaneous NTMs. This is a case of Mycobacterium botulinum, which was very difficult to diagnose, as we were unable to identify the species until this day 96. A case of Mycobacterium peregrinum, which is subspecies of botulinum, and you can see that yes, again, this like the chain of small nodules lacking inflammation. So when should we suspect cutaneous NTM infections? We saw some of the skin symptoms right now. They can be papules, nodules, abscess, sometimes they can ulcerate, or even it can be just an erythema. It is associated with very limited inflammatory signs like pain, warmth, and redness. Usually the clinical course, it is subacute or chronic. and it can prolong for a long time. There can sometimes be a presence of a trigger before onset. Also asking the risk factors, such as for like Mycobacterium maninum, if they have in contact with tropical fish, water. For others, some of the immunocompromised conditions can cause more infections to some specific NTMs. So asking the patients with these risk factors becomes important. This is a patient with a subcutaneous nodule. This is a patient from Ghana. I roll with this very severe edema on the face and this ulceration with deep ulceration with this necrotic tissue. And these are all the same disease. This is also the same disease in a different skin tone, and this is a patient from Japan. And this is a disease called Buruli ulcer, or Mycobacterium ulcerans disease. And this is the clinical course of this disease, that it first starts as a subcutaneous nodule, develops into a plaque, eventually associated with severe edema, and eventually the skin ruptures and become into a big ulceration. And this clinical course is known to be around 2 to 3 months. Characteristic feature of Buruli ulcer is this undermined wound edges, thick necrotic tissue, and limited pain. And these are photos from Côte d'Ivoire, West Africa, where I do my field work mostly. So you're wondering, so it looks quite different from other NTMs, this Buruli ulcer. Yes, because it's caused by not because of the bacterial growth, but the underlying pathogenesis of Buruli ulcer is this lipid toxin called the mycolactin. Mycolactin has several interesting functions, like cytotoxicity, immunosuppression, and activation of type 2 angiotensin II receptors, but more are being found about this molecule, which makes this disease also interesting. These functions are corresponds to the clinical features of Buruli ulcer. Since this is a lipid toxin, it has affinity to the subcutaneous adipose tissue. Therefore, the cytotoxicity, the necrosis happens in adipose tissue, therefore cause the deep ulceration with undermined edges. The immunosuppression causes a few inflammatory cells in the region, and also even with that big ulceration, the patient has limited pain. When you compare the histopathology of Buruli ulcer to other NTMs, this is what you see. So because the pathogenesis of Buruli ulcer is due to the mycolactin, and it has this immunosuppressant effect, you see very few inflammatory cells in these skin biopsies. As compared to the other NTMs, you see these granulomatous lesions with giant cells, and etc., which are specific to Mycobacterial disease, which you don't find in Buruli ulcers. So the pathogenesis of Buruli ulcer is very different from other NTMs. Epidemiology of Buruli ulcer is as shown on the slide, that there have been reports from over 33 countries now, worldwide. Accumulative global number of cases have been 73,000, but when we look at this annually, around 2,000 to 5,000 cases, new cases are reported to WHO. Most affected countries are Côte d'Ivoire, where I do my field work, Ghana, Benin, the neighboring countries, and other countries in West and Central Africa. However, there are also non-tropical countries that are affected, which is, again, make this disease interesting to at least whoever is working on it. that there are also patients in Australia and in Japan. And I'm from Japan, and I've been also experiencing some cases there. However, this does not mean the white areas of the map they don't have the cases of Buruli ulcer. It really depends on the physician's knowledge of this disease. And if you don't suspect the condition, you will never get to diagnose a case. And so there can be a largely under-detection and under-reporting of cases. So this is not just for Buruli ulcers, but for all the other NTMs. If we suspect a mycobacterial infection, we do the PCR and culture and histopathologies. But if these turn out to be negative, we wonder if this could be something else. However, also we need to keep in mind that not every area of the lesion is infected. So where you take the samples can affect your results. Also, culture condition may not be optimal. So negative can be false negative, and it actually can be NTMs. If possible, repeating testing is recommended, but of course we know that it's not most often not easy. Also, if the patient is already on treatment, then the effectiveness of this doing the test again decreases. So it's always a difficult question. So it's very important that in the first place, when you suspect a case, that you take samples, multiple samples. For example, if it is a wound, that you don't take just one swab samples, but you take swab samples from several different places to increase the positivity rate of these conditions. The slide is giving some of the key features of the common NTMs, and you can see that some of the temperature differences with the different types of mycobacteria, and also the growth speed. For example, like for Mycobacterium hemophilium, as also the name shows, that if you don't culture this species with hemin, which is blood, it does not grow. So sometimes you really need to be specific or do many, some range of conditions to have the positivity of culture. So diagnosing NTMs can be very challenging. This is Buruli ulcer, that these patients with that deep ulcerations, of course, if they don't get the treatment early, the delay in diagnosis and treatment can result in these lifelong scars and disabilities. And in many of the endemic countries, it is children that are affected. For any disease, early detection and treatment is a must. But for Buruli ulcer, there is treatment. If you administer clarithromycin and rifampicin for 8 weeks' time, these patients will have cure if they are detected early. So really, it is important that they get the diagnosis. And awareness of the physician is very important. So this is a case of a girl that which I showed you earlier. This was a case which we detected during one of our skin screening activities in Côte d'Ivoire. So she was able to get early diagnosis and treatment and full cure. And you can see how impactful this can be. This could have been for this girl. So to close, I would like to mention that please suspect cutaneous NTM infections when these 3 key signs which I introduced earlier, the skin symptoms, clinical course, and risk factors are present. Early diagnosis is very important, and the longer it takes to diagnose, the more challenging it becomes to diagnose and treat the case. Today I've gone through several clinical photos. I tried to also include some of the skin color photos in the series, but it was very difficult to find the literature on these conditions. So we see there are these gaps. But also my suspect is that in many of the countries which we know as low and middle income countries, many cases are not being diagnosed, and so there's no literature, and many cases can be misdiagnosed as cutaneous tuberculosis, where only microscopy is performed. And when we see acid-facet bacilli, I think, yes, they are just diagnosed as TB without going further investigations. So therefore, when, for example, pulmonary TB is absent, or there are some atypical conditions that are not matching cutaneous TB, please try to, if possible, look for other mycobacterial diseases. I serve as a reviewer for many of the Buruli ulcer papers, and often I get this sentence in the papers that Buruli ulcer is the most prevalent mycobacterial infection in the world, which is not true. It is the third most prevalent mycobacterial infection, which is reported to the WHO. This does not mean that it is the most prevalent. For other NTMs, we don't know the actual situation. The dermatologists need to suspect, and we need to know how we can diagnose the other NTMs. I'm not minimizing the interesting disease, Buruli ulcer, but we also need to be mindful of other NTMs. So this is all from me for this lecture, and I would like to once again thank the ILDS for giving me this opportunity to raise the awareness for the cutaneous NTMs. Thank you very much.
Good afternoon, wherever you are. My name is Wendemagegn Enbiale. I'm a professor of dermatology affiliated to College of Medicine and Health Science, Bahar Dar University, and Collaborative Research and Training Center for Neglected Tropical Disease, Ramam University. My presentation today is going to be on Mycetoma updates. As introduction, Mycetoma is the new member of NTD included since 2017, and it's a chronic, progressive, destructive infectious disease of the subcutaneous tissue that spreads to affect the skin, deep tissue, and the bone. There are different species of bacteria or fungi causing Mycetoma, and it is endemic in tropical and subtropical environments characterized by short rain seasons and prolonged dry season that favors the growth of thorny bushes. The Mycetoma geographical distribution is still unclear. In Africa, most of the cases of Mycetoma fall between latitude 15 south and 13 north, and the so-called Mycetoma belts. But beyond that, the most important thing is there is no really global data to show the burden of Mycetoma, the real burden of Mycetoma. But the disease is endemic in East Africa, Asia, Latin America. Most reports comes from Sudan, which is the highest number of Mycetoma, especially reporting on new Mycetomas. And the next high incidence is from Mexico, which usually reports the Mycetoma cases. And the other countries which have reported Mycetoma are Chad, Ethiopia, India, Mauritania, Mexico, Senegal, Somalia, Thailand, and Yemen. But Mycetoma has numerous adverse medical, health, and socioeconomic consequences for patients, community, and health service in affected areas. The primary reason for neglect is that it may affect the poor population in remote areas with a lack of trained staff, health facilities, and the diagnostic tools and treatment. Other factors which contribute for the neglect are the chronic course of the disease and the poor treatment outcome. The causative etiology known till now they can be classified into two, either the fungal cause, which is also named Mycetoma, and those which are bacterial cause, which are Actinomycetoma. And as you can see from the list, we have more than actually 20 species of Mycetoma, which causes the disease depending on this. The causative agents are spread in different environment and different part of the world. And mostly in Africa, the dominant cause of Mycetoma is Mycetoma, and in Latin America, most of the cause of Mycetomas are Actinomycetoma. When we think of the pathogenesis of Mycetoma or the disease development, there is still a lot to be learned. But so far, the evidence showed that a traumatic inoculation of the fungus from either the soil or the wood or stones or grasses introducing to the skin and subcutaneous tissue, and most of those organisms are saprophytes in the soil, and humans are an accidental hostess. And the disease, depending on the species of either the Mycetoma or Acetomycetoma, it has a variable incubation period, which ranges from weeks to months. And the infections evolve slowly, primarily causing a papule with some discharge, and those papules progress to be nodules and tumorous with multiple sinuses. Hematogenous and lymphatic spreads of the disease very much unknown. Most of the time, the disease affects the leg, either the trunk or the hand, depending on the introduction sites. And Mycetoma involves in the skin and subcutaneous tissue to form the classic triad of hard, woody swelling, painless discharge, sinuses, and presence of grain. These are what we call them, the classic triads. Swelling, discharge, and grains, the sinuses, which are colonies of bacteria. The grains are colonies of bacteria or fungi and vary in color and size, depending upon the species of the causative organism. And the clinical presentation of Mycetoma and Actinomycetoma are almost identical, with some subtle differences. The difference is exaggerated in the treatment response, not on their clinical presentation. Other clinical variants, including swelling without sinus, cystic type, and varicose type of Mycetoma, can be also seen. These are the different clinical pictures you see from the early case of Mycetoma, where in the left upper corner you see one or two sinuses swelling in the lower leg, the malleolar area, and then it can progress to a tumorous mass, a global swelling, multiple draining sinuses, and depending on the introduction sites, it can result also in progress from the subcutaneous tissue. It can result in bone destruction and disability. And depending on the site of the introduction, most of the time, around 60% of mycetoma cases are usually affecting the foots, but the disease can present at any sites of the body where the traumatic inoculation happens. It can be on the butt, the genitalia, trunk, and the shoulder, and even the scalp. So, when we think of the management of mycetoma, it depends on the causative agent that there is, whether it is eumycetoma or acetomycetoma primarily. But with the current treatment options, only 35% estimated cure rates for fungal mycetoma. For acetomycetoma, the cure rate can reach up to 90%. For eumycetoma or the fungal cause of mycetoma, current available drugs or drug of choice are itraconazole, fosravuconazole, and ketoconazoles, depending on the availability. And the recent clinical trial has shown that a much better treatment outcome from itraconazole and fosravuconazole, up to 69% response with a really good follow-up, especially if you give those treatments in adjuvant to a surgical debridement of the mycetomas. One of the issues we need to really consider is also those antifungal drugs has to be given for a year and more than a year. And for actinomycetoma, which is usually responsive, the antibacterial drug amikacin plus cotrimoxazole or trimethoprim sulfamethoxazole has shown a good response rate. That's Dapsone, amoxiclavs are the other treatment choices. And the other management modality is also the wound management of mycetoma, and we need to consider with open dressing, with daily or every other day cleaning of the wound, and orthopedic shoes. And the other most important component of the surgical management is surgery. And the surgery can have two components, either a complete removal of the lesion or reduction in size adjuvant to the medical treatment, which is usually advocated, especially with the evidence from the Sudan. In Sudan, for every mycetoma, for almost every mycetoma cases, in addition to the medical treatment, the surgical treatment is being also provided. The other is in advanced cases whereby the bone involvement is massive and there is no way to spare the limb. Amputation is also an option. So, when we think of the EU mycetoma, in general, the mycetoma and its impacts on the individual public health, the impact of mycetoma, especially among children and young adults of working age, and the burden that the disease places in the poor rural communities is a public health and socioeconomic problems. And the impact of mycetoma on individual is so serious. It can be from physical disability, as you can see from the picture from this case in Sudan, with amputation, economic challenge of those, primarily those people. Mycetoma affects the poor, and once they have the disease also, it can be disabling, further affecting their working condition. In addition to that, there will be the stigmatization of those people, which results in psychosocial impacts. A recent mapping study in Ethiopia, in Afar, showed that actually the evidence, even in the last 1 month, there were around 12 cases of mycetoma in one hospital, which had been seen by orthopedic patients, by orthopedic physicians. So, what's the solution, and what can we do? And the one thing is, globally, mycetoma has to be integrated into skin NTD framework, which is already happening. But at the same time, there is a need for a baseline data in the burden of the disease. In WHO Africa region, mycetoma was included in the national disease mapping by countries, and some countries like Ethiopia and Senegal are doing national mapping in the most affected areas. And there are development of sensitization tools are needed. So mycetoma mapping is going on some part of Africa and India. And the other most important thing is, even with the available drugs, which are a bit poor in their efficacy, the drugs are very much expensive, especially for the poor, costing more than the income of those affected. So the drug donation is the most important thing, and there is also more research on more effective drug and more effective management and networking and innovation to develop effective treatments. There are some ongoing projects with the Global Mycetoma Working Group, and the Global Mycetoma Surveillance Project is undergoing. Diagnostic training materials has developed, and research and development and access to antifungals is in a way, and exploring pathogenesis immunology of mycetoma. There are some already studies and pipelines, especially in Sudan and other parts of the world, and WHO standardized case report form is being drafted, and we think also the treatment guideline will be materialized. So, thank you for your attention. Thanks.